Right, we're going to smash some gastromed. I did do Gen Surge for a while, so I should know some things, but I can promise absolutely nothing. We've got some hepatobiliary disease and related disorders. Got a nice trifecta to get us going. I should do quite well here because we did do a lot of this on Gen Surge. So we have a 56-year-old woman known to have gallstones, severe epigastric pain and vomiting. On exam, she's tender in the epigastrum. I know what I'm looking at here. She has gallstones and severe epigastric pain. She's got pancreatitis. Is that one of the options? Acute pancreatitis. There we go. I think what we're going to do here, straightforward, clear cut. It won't be any of these other things. When you're thinking pancreatitis, it's either going to be gallstones or it's going to be alcohol. So yeah, for her, gallstones. Next up, we've got a 63-year-old man, presents weight loss anorexia. Denies abdo pain, stools have become pale and difficult to flush away. On exam, he's noted to have jaundiced sclera. Okay, so stools are becoming very fatty and pale. He's having weight loss and anorexia, no abdo pain. So it sounds like there's something happening with the biliary duct flow. And he has jaundice. Okay, he has painless jaundice. There's one thing that you need to think with painless jaundice. He's got weight loss, anorexia, stools become pale. Okay, this is actually quite straightforward. This is pancreatic cancer. Painless jaundice is the first thing you need to be concerned about. He's obviously got potentially pancreatic cancer. I'm very confident here, but what's happening is it's blocking the biliary duct outflow and not getting that tasty bile into the stool. And that bile is now backing up and giving him lots of, it would be conjugated bilirubin at this point because it would be post-hepatic. But we'll do some blood tests, pancreatic cancer, get this man some scanning. Now, next, a overweight 47-year-old woman presents with recurrent pain in the right upper quadrant brought on by eating fatty food. So when you're thinking pain in the upper right quadrant, you're thinking it's related to the gallbladder or liver or a number of other things, but brought on by food. So this sounds like it could be a cholelithiasis. What have we got here? Ascending cholangitis. No, ascending cholangitis, you'd have that triple threat of fever, jaundice, and pain. It sounds like the pain comes and goes. Acute cholecystitis, she's got no fever. That's just by eating food. So I'm thinking biliary colic. That sounds the most fitting picture here. It's not going to be any of these other things. We're very much thinking to do with the bile duct. Okay, let's see. All right, we're off to a good start. Now, we have a 23-year-old woman presents to GI outpatient clinic following admission for the first presentation of Crohn's disease. She's now recovered and would like to start medication to prevent recurrent flares of Crohn's. I don't know much about the meds on Crohn's. First-line medication to maintain remission in a patient with this condition. So I know that we do, pretty sure budesonide and prednisolone are shouting at me, but we don't do that long-term. Infliximab, I've seen people on all these, but mesalazine is shouting out to me most. I could be getting confused with ulcerative colitis, mercaptopurine. I'm trying to think. I'm not sure if I've seen it that much. Infliximab I've seen, but they've been quite bad cases of Crohn's. I'm not super certain of this. All right, there we go. We can take some vindication in going with the masses here. Thioprine or mercaptopurine is first line. These are the things that you just gotta learn, I suppose. What we're saying about infliximab, biologic medication used to maintain remission of Crohn's, but it's not going to be first line. It's used when mercaptopurine or azathioprine have failed. And what we're saying about mesalazine usually is used for the remission of ulcerative colitis. All right. Okay, I haven't seen mercaptopurine used a huge amount, but then again, I haven't been on a gastro ward or in a gastro clinic. Let's see the next ones. Most likely diagnosis here. A 25-year-old female currently investigated for secondary amenorrhea presents with jaundice on exam, Spider nevi are present along with tender hepatomegaly. Bloods show the following. HB is fine, platelets bit low, white blood cells fine, albumin fine, bilirubin up, ALT very up. Okay. She's too young for hemochromatosis. What we're thinking of hemochromatosis is someone who's got the arthralgia and that iron build up over a long amount of time, usually in their 50s or so. Wilson's disease, no, we'd be expecting some neurological signs, and they definitely talk about copper in the irises. Okay, PBC, PSC, and autoimmune hepatitis. Bilirubin, it's up, but it's not that up. Let's have a look at the reference ranges here. Oh, it is really up. So the reason I'm thinking PBC or PSC is she has all this stuff going on. Is there I know PSC is linked to ulcerative colitis. They're not talking about that here. PBC is another autoimmune condition. It's very hard to know. Autoimmune hepatitis. Could it be that? Spider nevi with tender hepatomegaly. So is the liver getting enlarged? ALT is pretty high. That is really high. I really love... So what's difficult here is I'm trying to determine, is this more a hepatic picture or a cholestatic picture, to try and figure this out. We haven't got a full suite of blood tests here to go by, so I'm not hugely certain. As I can't really decide between these three, I'm going to go in the middle and see. Okay, our rationale might not have been there, but we got it right. Autoimmune hepatitis strongly suggests autoimmune hepatitis, typically young females of amenorrhea. Okay, I didn't realise that. Bloods do show a hepatic picture, maybe with clinical signs as well, of a chronic liver disease. Everything's more obvious in retrospect. Next. Whoa. Okay, this looks like it's a more practical question. Let's see. A 30-year-old woman presents with a 3-month history of indigestion. No history of weight loss, anorexia, dysphagia. No history of vomiting or change of bowel habit. She's just had some indigestion. Abdo exam is unremarkable. Which of the following may decrease the accuracy of the 13C urea breath test? Okay, so we're seeing if she has got a H. pylori by doing this test. Avascon, it's an antacid. Don't think it will do much. It may help symptomatically, but I don't think it impacts anything to do with H. pylori. Ranitidine, I don't know if there's weird rules of ranitidine, and because I know PPIs are meant to be stopped 6 weeks before, and ranitidine is a H2 antagonist. I actually don't see a ranitidine prescribed that often. I feel like I saw something in the BMJ about not prescribing it so much. It's not first line anyway. Amoxicillin 3 weeks ago. I bet there's going to be a time cutoff for the amoxicillin. It's 3 weeks. Why was she taking amoxicillin anyway? I don't know about the amoxicillin either. PPI stopping 3 weeks ago. That sounds fine. And current use of combined pill. There might be something weird and wacky impacting that. I don't know if it's PPIs and agonists have to be stopped 6 weeks before, but let's see. No, not doing well here at all. Oh, okay, I was right. I was thinking about amoxicillin. 4 weeks for no amoxicillin. Okay, and no anti-secretory drugs like PPIs in 2 weeks. Oh, fine, okay. All right, I'm just scrolling down here to try and get some more info. All right, so this is just for the urea breath tests. That's 2 questions wrong. We don't have much more leg room. Diarrhea. We can do some diarrhea. Famous last words. Let's see how we do here. Okay. For which of the following scenarios, please select most likely diagnosis. We have a 41-year-old man with cerebral palsy admitted with abdo pain and diarrhea. His carers report 5 to 6 watery stools. On exam, he has a mass on the left side of the abdomen. Abdo pain and diarrhea. What do you think it could be? Don't think gastroenteritis. Is it Crohn's or ulcerative colitis flare-up? Abdo pain, diarrhea. No previous history. He's 41. There's no other hallmarks for it. He's got this mass on the left side of the abdomen. Are we thinking colorectal cancer? I feel like they'd talk about some blood or something in the stool to make me think more ulcerative colitis or colorectal cancer. I'm not talking about laxatives here. I'm in favour of the constipation. See, lactose intolerance, diverticulitis, IBS, abdo pain, diarrhea. It's a lot of stools, watery. I think this is the real crux of it. Massing the colon. I don't think it's colorectal cancer, but I'd talk more about other hallmark features. Number 7. Let's see. 37-year-old woman presents with a 3-week history of diarrhea, crampy abdominal pains. On exam, you notice she has a number of perianal skin tags. Okay. Seen many perianal skin tags on GenSurge. Also saw many hemorrhoids on GenSurge. 3-week history of diarrhea and cramping pains. They're giving very vague histories. It must be about skin tags. Skin tags. I feel like skin tags are an extra manifestation of Crohn's. Or anything else here? Skin tags. Yeah, I feel like it's Crohn's. I don't think it's related to anything else. Now, what 4-year-old boy investigated for chronic diarrhea, abdo bloating. These histories are really broad, but we're going to go off failure to thrive. In a 4-year-old, constipation is extremely common. Then chronic diarrhea. Kid says you can get this constipation. I've already put constipation for the cerebral palsy man. Okay, what are the options? Not gastroenteritis, not Crohn's, not UC, not colorectal cancer, lactose intolerance, 4 years old, abdo bloating, diarrhea. Hey, okay. Celiac disease. That sounds more failure to thrivey. I bet this kid has a tiny spleen. Alright, we're gonna go 5, so I could get this all wrong. Okay, we're doing okay here. Yeah, fine. I just didn't see the celiac disease until the end. I'm happy we got that constipation. That's tricky. Patients with severe chronic constipation, especially with those with neurological disorders such as CP, may develop overflow diarrhea. Fine. I think we're quite happy with that. Alright, let's see this. Oh, we like to do 10 questions at a time, so let's just call it here. We need to get this one right. A 55-year-old woman, history of alcoholic liver disease, reviewed in clinic, advanced cirrhosis, and started to accumulate ascites. Alright, acetic tap, recently performed, showed protein concentration of 12 grams per litre. Is that a lot? Is that not a lot? And no evidence of any organisms. Okay. So if you're thinking a big belly, you're concerned about SBP. So a spontaneous bacterial peritonitis. Hey, what's the most appropriate management concerning the risk of SBP? Okay, so we don't think that she has it? Or does she have it? Is this a high value? Do you give antibiotics anyway? I have no idea if this is a normal value or not. Or what you do if okay, if you've given a bunch of antibiotics, I'm thinking you might just give antibiotics. What have I seen? Ciprofloxacin here. Or maybe azithromycin. I don't think doxy and I don't think penicillin. Could no antibiotics be indicated if there's no organisms? You're probably going to do it anyway. Prophylactic antibiotics if you're worried. It'd be good to have some references. Alright. Patients with ascites, it's less than 12 grams per litre, should be given oral ciprofloxacin or norfloxacin as a prophylaxis against SBP. No antibiotic is not appropriate due to the patient's increased risk. I think I'm happy with that. Hey, and that's 10 questions. Alright, let's jump in cock.